Good morning, students. Well, I know that starting a lecture with assignment is not a good way to start, right? But in last lecture, I just forgot to give you assignment, and don't bother about the assignment because I know that your exams are very near. But just to give you a hint that what type of questions could be asked, and more importantly, that if from this question, if you will try to find, definitely the learn topics, right, the topics that you learned, that you will be able to understand in a better way. Okay, that is the only purpose for the assignment. Don't worry about writing these details, right? Definitely once your exams are over, then definitely you can complete and submit to me. Fine. So these are some comment like questions that could be asked, right? So primaquine and chloroquine, definitely they are used in combination for treatment, like say for example plasmodium vivax infection. Similarly, hydroxychloroquine, you all know that is recently used for coronavirus infection, COVID-19, but it is from many years, right? It has been already there in the therapeutics for treatment of malaria as well as for rheumatoid arthritis. Okay. You can definitely explain these terms, right? We have discussed in the lectures, you just have to go through this. And finally, yes, this is what maybe we have not discussed in detail, but if you will try to find out, this is right now very important because in many part of the world chloroquine has become resistant, right? So many species and most dominantly plasmodium falciparum, right, the resistance is seen, is observed in this you can say parasite. And if resistance has been found, what will be the therapeutic plan for such type of infection, right? That is what you need to find. Okay, so without wasting time, let's start with the remaining drugs, and do not forget to check the details at the end of this lecture, which are very important. Novel targets, novel drugs that are used or that may be available in future, right, as an anti-malarial drug. That is a very interesting and important topic that I included in this lecture. Fine. So drugs affecting synthesis or utilization of folate. Okay, so you know that there are two types of antifolates, type 1 antifolates and type 2 antifolates. Okay, type 1 antifolates includes sulfonamides, right? Say for example, sulfadoxine is predominantly used from the sulfonamide category. There are lots of sulfonamides, short acting, long acting, medium, intermediate acting, right? So out of that sulfadoxine, right, it is predominantly been used as an anti-malarial drug, definitely in combination with the type 2, that is type 2 antifolate includes your pyrimethamine, right? So pyrimethamine, proguanil, both are inhibitors of dihydrofolate reductase enzyme. These are inhibitors of dihydroteroate synthetase enzyme. Okay, we will check definitely the pathway, right, how this antifolate 1 and antifolate 2, right, type 2 antifolates, they do act. Okay, but examples definitely you need to remember, right? Sulfonamide, definitely sulfadoxine we have remembered, and sulfone, only sulfone that is used, that is dapsone. You know that dapsone is also used in treatment of leprosy. Okay, and it is also having a very good anti-malarial action. Fine. So these are two types or classification, right, that you can consider for this category. Okay, now moving towards the mechanism of action. So you know that just like bacteria, plasmodium species also utilizes PABA, right, that is para amino benzoic acid, for the synthesis of folic acid. And this conversion, or you can say utilization of PABA, right, for converting into folic acid, right, folate salt, is by this enzyme, right, because folic acid is having a ring structure that is called as a teichoic acid ring structure, right. So that is why I have mentioned is a dihydroteroate synthetase. Some book also suggest it as a dihydrofolate synthetase, that also is right, but more appropriate name is dihydroteroate synthetase, because ultimately we are interested in synthesis of teichoic acid ring structure. Okay, so PABA is utilized, right, as a raw material by many, you can say, unicellular organisms including plasmodium, right. This is also applicable for bacteria, right. Also same thing you can just consider for the plasmodium species. Now this dihydrofolate, you can say, once been synthesized, it still needs to be reduced, right, and after reduction definitely you can say you will be able to convert into tetrahydrofolate structure, right. So because there is a reduction. Very easily you can just check, here it is a dihydro and here we are converting it to tetrahydro, right. So, from that you can just consider that the reaction is reduction, right. So, which compound is reduced? So, it is definitely dihydrofolate, and that is why the name of enzyme is dihydrofolate reductase. Okay. So, once it is reduced, now it is available in a form of tetrahydrofolate. This definitely now can be incorporated to synthesize some of the intermediates like thymidylate, right, and definitely once these intermediates are synthesized, then purines, and definitely DNA synthesis could occur, right, and definitely then protein synthesis could occur, right. So, Plasmodium species can multiply. So, for synthesis of protein, this you can say that the pathway, right, this is a class 2 pathway, biochemical reaction. If you recall the basics of chemotherapy, this pathway is a very important one, right, and there are two targets, right, that is dihydropteroid synthetase and dihydrofolate reductase. These are two enzymes which are available to us, and this both of these are a very good target, right, what you call as a selective toxicity that we can use to reduce the growth, right, to stop the growth of you can say that Plasmodium species, because we are just reducing this or we are just stopping the growth. That is why it is not a cidal action, it is static action if used individually, right. This drug, say for example dihydropteroid synthetase, if I inhibit with sulfonamide, sulfonamide produces static action, it does not lead to cidal action, okay, because we are just inhibiting the protein synthesis pathway, that is all, nothing else. Yes, but if you sequentially block both of these enzymes, then it leads to a synergistic action and then it produces a cidal action, okay. So, that is a very important mechanism. Maybe you have learned for the bacteria also, same pathway we have revised, we have discussed with the Plasmodium species. Definitely in humans such pathway is not existent, and you just know that it is a dietary folate, right, which has been taken up by cells with special transporter mechanism, right, and that leads to DNA synthesis. So, you do not have synthesis of this folic acid in the human cell, and that is the reason why this is a selective toxicity, right. It will not interfere with any mechanism in case of you say the human, okay. That is the basis of selective toxicity. Now, name of these enzymes definitely are important, and their drugs, right, which they inhibit, that also we have learned, but just we will mention here sulfonamides and sulfones, right, both you need to remember, and definitely these are a competitive you can say in a reversible type of inhibition. If PABA is increased, right, maybe PABA like structures are available, then definitely the action of sulfonamide can be reduced, like say for example PABA esters, you know that local anesthetic agents, or say for example presence of pus in case of bacterial infection, right. In case of Plasmodium infection, presence of pus is definitely not an issue, but such type of you can say structural analog of PABA, if they are present, then definitely they will compete with the sulfonamide, and you can say reduction in the action of sulfonamide can be observed, fine. So, sulfonamide both are type 1 antifolate, and they do inhibit this enzyme dihydropteroid synthetase. Type 2 antifolate are these drugs, you can just see that pyrimethamine, proguanil, these both agents pyrimethamine and proguanil, these two are anti-malarial drug. Methotrexate is anti-cancer, trimethoprim is antibacterial, right. Why such different therapeutic uses have been there? That is because they have preferential selectivity for the organism. Say for example pyrimethamine is having preferential selectivity for Plasmodium dihydrofolate reductase, right, if you check in the in vitro analysis, right. Similarly, methotrexate is having more selectivity towards the human dihydrofolate reductase, and that is the reason why methotrexate is used as an anti-cancer. Trimethoprim is having more action, manifold higher action in the bacterial dihydrofolate reductase, and that is the reason why it is an antibacterial agent, okay. So, such an important mechanism we have learned, right, very easy mechanism also. Moving towards, yes, this is what we have learned, right, this produces individually, they produces schizontiostatic activity, but when you go for a combination therapy, sequentially both enzymes they get blocked, then it produces schizondecidal agent, and that is why sulfadoxine and pyrimethamine, they are always used in combination, right, they are not given as a single agent, okay, remember this fact, right. This is structure of folic acid, just to understand how this drug they are working, or what is the teichoic acid ring structure, right. Otherwise in pharmacology you do not draw these structures, right, you do not need to draw these structures, fine. Moving towards the pharmacokinetics, I am not going in a detailed pharmacokinetics of sulfonamides and proguanil here, right, because that somewhere we are knowing, we have discussed in the antibacterial class what is more important, right, something which is peculiar, that is what we are going to discuss. Definitely for sulfonamides the absorption could be you could say variable, but here for you could say or so say for example some drugs like pyrimethamine proguanil, right, which we have not discussed earlier in the sulfonamide category or as an antifolate drug, then definitely you need to know that pyrimethamine and proguanil both have slow but a complete absorption profile, right. So definitely they are very good when they are given by oral route. Pyrimethamine half life is long, which is advantageous, right, and that is why it is taken once a week, fine. For proguanil, remember that it is a prodrug, and once been taken inside, it gets converted into cycloguanil. Cycloguanil is the one which is an active molecule, okay. And sulfonamide, you definitely know that the protein binding is quite high, and such a case important drug interactions, right, which are related with the protein binding displacement, that definitely you need to consider, okay. Sulfonamide, you also know that sulfadoxine, there is also chance that this whatever acetylated metabolites that are produced, right, once been taken sulfonamide, they in liver, through liver, it gets converted to acetylated you can say sulfonamides, and these acetylated metabolites, they have a lower pK value. This lower pK value, if urinary pH is also an acidic, then it definitely will get precipitated, because acids will not be able to, because weak acid will not be able to get that easily solubilized in case of acidic pH, and that could result in what you call as a formation of crystals, right, and such formation of crystals in case of urine, that is called as a crystal urea. Crystal urea is a characteristic adverse effect of all sulfonamide including sulfadoxine, right, but the doses which are used for chemoprophylaxis again will not lead to generation of such type of an adverse effect, okay. So here you can consider that definitely at the doses which you are using, right, which doctor recommends, chances of such type of you said adverse effect are less, but if been produced, then patient should be advised to take more water, should advise to go for, if still not been managed, then you advise the patient to go for some drugs which you call as urinary alkalinizers, like you can say that acetazolamide, right, or that is carbonic anhydrase enzyme inhibitor, or you can also you can say advise the patient to go for, or you can definitely indicate the drugs like sodium bicarbonate, right. These are some of the therapeutic options available if crystal urea is observed then. Fine. Unwanted effects, as I told you that fewer and unwanted effects if used carefully, but in large doses definitely it can lead to hemolytic anemia, right. This is definitely an adverse effect of, because of that sulfonamides which you have checked in the earlier also. Wherever sulfa drugs are there, allergic reaction, skin reactions are always possible. So agranulocytosis, skin reactions, urticaria, these all are possible cases with the large doses, right. I have not mentioned a crystal urea, but then definitely you can add here, right. Pyrimethamine is not having that severe adverse effect, but still when you go for a combination, such type of adverse effect could be observed, okay. Now moving toward the therapeutic uses, right, as we have seen that in case of chloroquine, definitely it is a first choice drug, right, but with the emergence of resistance in case of chloroquine, definitely second choice you need to recommend, or in cases of resistance you need to go for another therapeutic plan. So in that case definitely sulfonamide, your sulfadoxine pyrimethamine combination definitely was one time was used as a very important alternative, but now it is less effective because emergence, right, of resistance, and this is in most of the part of the world, and because of this reason now this combination is not that effective, right, it is less effective, right. So definitely effectiveness is less, but still we need to discuss, right, on which type of stages of plasmodium life cycle it acts. So it is having definitely action against all you can say the stages of erythrocytic you can say growth, right, that is endoerythrocytic cycle. Slow action is there, but definitely it will produce definitely all forms of the erythrocytic stage, but there is no effect on hypnozoids, right, that we already learned in the last lecture, and that is why it can be used for acute attack as well as for the chemotherapeutic chemoprophylaxis purposes, okay. No action on the gametocytes also, that is why it cannot be used to prevent you can say that the transmission, and hypnozoid also there is no action, fine. So this is all about the user. Yeah, just I forgot to mention, yes, gametocidal activity is there, moderate activity is there, right. As I have mentioned here, erythrocytic form, all action against all type of stages of erythrocytic form. So moderate activity against the gametocyte also is observed. Only sleeping forms, right, that is hypnozoid, that is exoerythrocytic phase, it is not having the action. Fine. Regarding the you can say sulfadoxine and dapsone, it is definitely more active against the Plasmodium falciparum and less active against the Plasmodium vivax, right. But as I have discussed that with the emergence of resistance, effectiveness is not as good as we are predicting. Fine. So moving toward the next one is your 8 aminoquinolines, and that is primaquine and itaquine. Okay. Now these compounds were initially been used that came into the picture, right, with the observation that methylene blue, you know that it's a dye, right, which we use for many purpose. So that dye, right, during the World War II, that was shown to have a moderate activity against some of the Plasmodium species, and that lead to research which lead to a series of 8 aminoquinolines, and few of those 8 aminoquinolines, that like primaquine is a very important drug. Primaquine is a very important because you have very few drugs which are active against the exoerythrocytic phase. So for treatment of Plasmodium vivax, Plasmodium ovale, you need to add this drug in combination. Fine. And that is the reason why it's a very important drug we are discussing here. Mechanism of action is not that clear, but right, it is been reported as an unknown by many books, but yes, you can convert, you can just assume, right. Many books have mentioned that this could be a postulated mechanism, right, that is possible for the schizonticidal activity for primaquine, right. So initially the drug is converted into some electrophilic intermediates, and that acts as an oxidation reduction mediators. Now these mediators, right, that contribute, you can say, for the generation of this reactive oxygen species, right, within the Plasmodium, you can say species, and by generating such reactive oxygen species, they interfere with the electron transport chain. You know that this mitochondrial ETC is very important for, you can say, generation of, you can say, ATP, right. So this once ETC is been disturbed, right, mitochondrial function is been disturbed, definitely you could have a very good schizonticidal activity, right. That's how these drugs are acting. Pharmacokinetic, definitely the absorption is near about 100%, right, by oral route. So that's a very good point. Metabolism is through liver, right, and metabolism will give rise to inactive metabolite, right, and that is carboxy primaquine, right. Additionally, it is also a very good inducer of cytochrome P450 enzyme, and the isoform which gets induced, that is CYP1A2. CYP1A2 is also responsible for metabolism of some of the important drugs like warfarin. Warfarin definitely predominantly gets metabolized by CYP3A4, but this variant, that is A1A2 also is responsible for the metabolism of warfarin. So such type of drug interactions are possible, right, with the primaquine. Volume of distribution is very high because of the extensive tissue binding that is observed with this type of drugs. Unwanted effects are mild and infrequent, but still, because of that you can observe some of the effects like abdominal distress. This is again mild. When you give a larger dose, then this becomes a problem, right. But at therapeutic doses, these are very mild. Okay. Similarly, anemia also, therapeutic dose very mild, but at larger doses it could lead to a problem. Yeah, here it is very important to note that this drug cannot be given in a patient, right, in a population who is deficient in G6PD, right. So if such type of genetic disorders are there, then it will lead to acute hemolytic anemia, okay, and then the problems are severe, right. So such population definitely needs to be screened, and they cannot be given drugs like chloroquine, like quinine, similarly primaquine also, okay. Yeah, one more problem is methemoglobinemia, right. Methemoglobinemia means increase in the blood concentration of methemoglobin. Now hemoglobin you are already knowing, methemoglobin is a type of a hemoglobin, right, is a product of a hemoglobin. When hemoglobin acts with some of the environmental pollutants, right, or some gases, right, and in that case if Fe+2 which is present within the porphyry, which is shielded by your porphyry ring, normally does not get oxidized. But if environmental pollutant you can say have been there, right, say for example some of the gases, right, like nitrous oxide, such a cases that will convert Fe+2 into Fe+3, and such oxidation will lead to generation of methemoglobin. If this methemoglobin is higher in the blood, that is called as a methemoglobinemia, right, which is also referred as a cyanosis, right, because cyanide can also produce such type of an action, definitely in more severe context, but here such effect also can be produced by primaquine, and that is called as a methemoglobinemia. But this is, as I told you, is a very mild effect. It is not affecting the therapeutic usefulness of primaquine. Leukocytosis also can be observed. Therapeutic use is excellent use, definitely, because it is having a tissue schizoidicidal action, right, what we have discussed under the category of the drugs which are used as a for the radical cure, right. So here they are acting on the hypnozoids, okay, and exoerythrocytic cycle. That is why it is very much important for treatment of Plasmodium vivax, Plasmodium ovale. Also remember that primaquine is having an excellent gametocidal activity, right. From the current list of anti-malarial drug, right, the best action against the gametocyte is produced by primaquine, and that is why it is most effective anti-malarial drug for preventing the transmission. Although for such single use it is rarely been used, okay, no one uses for prevention of transmission, but still it could be a very good agent that you can consider, right, that additional benefit once you are giving for radical cure or maybe say for examples for other purpose, this could be considered as an additional benefit, right, or you can say therapeutic role of primaquine. Does not have any action on sporozoites, that is why no true prophylaxis that you can consider, and also no action on the erythrocytes. So for acute attack it cannot be used, okay. So these are very important therapeutic use. Moving towards the last drug, right, that we are going to discuss from the currently available anti-malarial drug, and that is Artemisinin, right. Now you all know that neither me or nor you are very good in pronouncing the Chinese language, right, and in previous case I may have pronounced it as a King Hao Shu, but it's actually been pronounced as Ching Hao Shu, right. So that's a very comic way to pronounce, but then that's the actual pronunciation of this ancient, you can say herbal phytoconstituent, that is Ching Hao Shu, right, Artemisinin, right. So it is an active principle of Chinese herb, that is Artemisia annua, okay. So from cognosy point of view it is also very important. Current anti-malarial drug, it is the best drug you can consider, right, considering the case that chloroquine is now become resistant, right, there is an emergence of resistance, that is why the use of Artemisinin is been arising, okay. Chalo, mechanism of action is a very important thing and many a times been asked in the GPAT examination, or also individually pharmacology of Artemisinin definitely is a very important question in the exams, right. So knowledge point of view, exam point of view, competitive exam point of view also, these are very important detail. Now you can just see that a typical structure, very atypical structure you can say that, and that is peroxide bridge, right, because this is within the you can say ring structure, that you can, that's why you call it as an endoperoxide bridge, right. So Artemisinin is a sesquiterpene lactone ring structure which is containing an unusual endoperoxide bridge, right, and this endoperoxide bridge is thought to have a very important role in the anti-malarial action, okay. It is prodrug, right, and once been taken inside, then it will get converted biologically active metabolite, and that is dihydroartemisinin, okay. So this is the active constituent itself. Also sometime it is being used, right, directly dihydroartemisinin also can be used, but definitely Artemisinin is the most widely used, that is why we have mentioned in this way, right. Now there are some issues with this pharmacokinetic profile of Artemisinin as well as dihydroartemisinin, and that is why scientists have developed some of the derivatives, right, like say for example artemether and artesunate, right. So pharmacokinetic profile of these two derivatives are smoother, and that is why they are preferred, right, over these two compounds. Now what is the exact mechanism of action? Now this you can say that iron of the heme, you know that once the plasmodium is you can say that is multiplying within the erythrocyte, right. So it will lead to generation of iron also, right, free iron, and this iron of the heme that reduces this peroxide bond, right, peroxide bond which is present in the artemisinin, which we observed as an endoperoxide, right. So, this iron, once it reduces this peroxide bond, then it leads to generation of a high valent iron oxo species. This is a very important structure, right. So, iron oxo species, this is resulting in a cascade that produces a very highly reactive oxygen radicals, and once you know that these radicals are generated, they will damage the membrane of the parasite, they will damage the nucleus of the parasite, and these events, right, the cascade which is generated by this reactive oxygen species, that eventually leads to CIDL activity, right. So, this is a mechanism, this mechanism is many a time been asked in the competitive examination, and this is also important as far as the medicinal chemistry of these compounds are considered, right. So, mechanism of action, just go through the details of this, right. Now, moving towards the you can say pharmacokinetics, as I told you that bioavailability is poor, pharmacokinetic profile is comparatively poor for artemisinin, and definitely that limits its effectiveness, right, and that is the reason why derivatives, semi-synthetic derivatives are developed. So, major you can say that semi-synthetic derivatives are artesunate and artemether, right. Artesunate, remember, is a water soluble semi-synthetic derivative, right, while artemether is a lipid soluble type of an nucleoside structure, right. So, from ether, right, you can just remember lipid soluble whatever way you are going to remember, but you need to remember that artemether is a lipid soluble type of an structure, right. Both of these drugs, right, definitely can be given by various routes of administration, oral, rectal, intramuscular. Here depot therapy also is used many a time, right, intravenous also is possible because it is water soluble. Here oral, rectal and intramuscular, you can say that options are there. Intravenous is not possible because it is a lipid soluble drug, right. If it is used by intravenous, definitely it will lead to a problem in the, you can say that viscosity, right. Such cases definitely intravenous use is not recommended, is not possible. Okay. Now, other semi-synthetic derivatives also have been prepared, right, but they are not that widely used therapeutically, right. So, we will see the examples. Definitely this is the bioactive constituent dihydroartemisinin, so that definitely can be used, but these are some of the other semi-synthetic derivatives which are not as you can say that known, right, compound, right, as far as the therapeutics are concerned. So, artelinic acid, artenimol and artemotil, right, these are some of the other compounds which you can definitely discuss. So, you go for a detailed pharmacokinetics of this artemisinin semi-synthetic derivatives, okay, and that will definitely complete your pharmacokinetic. Most of the details we have discussed in the previous slide, but still if some advances are there regarding the pharmacokinetic development regarding the pharmacokinetic parameters are there, it is my request you to go through that details, right, which will be very important, right, as far as the knowledge is concerned. Metabolism definitely is through liver, as we have discussed, it is a prodrug, and active metabolite is dihydroartemisinin. Now, regarding the hepatic metabolism, right, it is a very important inducer of cytochromal enzymes, microsomal enzymes, and two you can say forms, right, alleles, that is 2b6 and 3a4, they get induced. As I told you that this CYP3A4 is involved in metabolism of many important drugs, right. It is the major enzyme that you can consider, right, pharmacologically, right, when it comes to the drug interaction which are related with the hepatic microsomal enzyme induction. So, there you can consider artemisinin, right, drug interaction profile, right, that you can definitely you can consider, right. So, this definitely two examples which are variant are very important, right, CYP2B6 and CYP2A4 both are induced by artemisinin. Additionally, it is a rare example where it is inducing its own metabolism, right. You will find only few examples in pharmacology, right, where the drug is inducing its own metabolism, right. Say for example carbamazepine, right, which is anti-epileptic drug, is inducer of its own metabolism. Similarly, artemisinin also induces its own metabolism, and with you can say consecutive doses, almost 5-fold increase in the metabolism of artemisinin is been reported, right. So, dose adjustment, right, with the consecutive doses definitely you need to consider. Yeah, gametocidal activity, schizonticidal activity of artemisinin is very good, that could be checked by its in vitro profile, and from the in vitro profile whatever doses that are being decided for artemisinin, that requires almost 2 or 3 cycles, only 2 or 3 you said doses of artemisinin, and that is definitely a course of 6 to 8 days, not more than that, right. This is enough to eradicate the plasmodium, right, from the body, right. Definitely again the course will be definitely decided by the physician. Dose also definitely can be varied as per the patient to patient, but on an average 6 to 8 days are enough to completely eradicate the plasmodium from the blood, right, and that is the advantage with the artemisinin, right. So a very effective therapy that you can consider, right. Chinese medicines, the ancient literature in the China that has reported this use of this Chinese herb many years ago, right. It is something like 350 AD, right, that they have reported. So it's a very ancient drug, that also you can consider here, fine. So yes, moving towards the unwanted effects, fewer and very infrequent. Some of the infrequent and fewer adverse effect include decrease in neutrophil count, brief episodes of fever, right, transient head block, right, but as I told you that these are fewer and infrequent adverse effect. Yeah, embryotoxicity in preclinical studies they have been reported, and even in the initial clinical studies that have been reported, and that is the reason why it is not recommended in the pregnancy as well as the child below the 5 years, right. That is a disadvantage, because if malaria is there in case of child, then definitely it is not recommended, okay. So that's one disadvantage that you can consider. Resistance, fortunately there is no resistance reported till, right, and to prevent the chances any chance of emergence of resistance, WHO has recommended that it should always be given in a combination therapy, right, and that's what is called as a, because of that, artemisinin based combination therapy, which is right now a main a theme or a major you can say part of management of malaria, right. So artemisinin based combination therapy is very effective, right. You can just go through, right, that's an assignment also from my side for today's lecture, right, and you just go through the combination, various combination, right, that you can give with the artemisinin, right, and this you can say therapy has definitely helped in this last 5 years. It has definitely helped us to cope up with the malaria, right. If not able to decrease, we are able to flatten the curve, right. So number of cases which were rising gradually in the last 20 years, if you compare the chart with last 5 years, now that graph is either flattened or is been slightly reduced, and that is largely because of the use of artemisinin based combination therapy, right. So this I strongly recommend you to go for detail of this topic, okay. So with this we have completed all details of the current anti-malarial drugs, and definitely current status if we discuss, then it is significant impact by anti-malarial drug, as well as some of the preventive therapies, preventive measurements that have been taken by various countries recommended by WHO, and that has definitely reduced the incidences of malaria, right. That has definitely reduced the epidemiology of malaria, okay. So prevention, the best you can say the preventive measurement that is taken by insecticidal treated mosquito nets, right, bed nets which are being treated with the insecticidal. So that definitely has prevented in the major area. This is very much effective in case of African countries, and treatment wise if you just check, then the you can say that the definitely the artemisinin based combination therapy, that is the main theme, right, which has created a significant impact, okay. So both of this, prevention as well as treatment, right, this success has definitely achieved, that is important, right, as far as the pharmacy practice, clinical you can say practice is being considered. Now considering the recent advances, there are many you can say drugs which are being emerged as a new anti-malarial compounds, and that is through the you can say a concept of drug repurposing, right. You know that drug repurposing nowadays also is used in case of COVID-19, say for example hydroxychloroquine, right, that is what you call as a drug repurposing, right. Similarly ivermectin, right, or maybe say remdesivir, right, these are some of the drugs, right, which are previously used for some other drug for some other disease, but now it is tried for treatment of COVID-19, okay. Similarly some drugs like say for example rosiglitazone, right, which is anti-diabetic drug, but then because in laboratory testing in vitro models, right, or maybe in cell line models, right, you know that now complete genome of Plasmodium falciparum is available, and genome based screening, in silico training, in vitro models, in vivo models, these are all because of facilities now available with the research and development unit, and now they have checked, right, that this drug, right, rosiglitazone is having very good anti-malarial action. Similarly, methylene blue, which is used for treatment of methemoglobinemia, right. Similarly, phosmidomycin, right, which is antibiotic, imatinib, which excellent anti-cancer drug, cevuparin, right, this is a drug used in sickle cell disease. These all drugs now they are, you can say, been tried, right, in vivo also, right, and clinically also they have been tried in cases where the primary drugs, right, chloroquine, artemisinin is not able to manage the symptoms of malaria in case of, you can say, that patient. Such cases these drugs also can be used, right. So that's a recent development, right. We have used the concept of drug repurposing, fine. Additionally, we also have to identify some novel targets, right, because whenever there is an emergence of resistance, one of the major theme to cope up with the resistance is to identify a novel mechanism of action. Then and then you will be able to cope up with the resistance. So some of the novel targets that we have identified, right, that I am discussing today. Okay. Remember that these drugs are still investigational, they are either in preclinical stage or a clinical stage, phase 1 or phase 2. The drugs which are targeting these novel targets, right, they are still not in the, you said, market. Okay. But yes, as an Pharm student, right, or maybe if you are preparing for a GPAT examination, maybe for NIPER examination, such type of an identification of novel target is a very important, right. Maybe in futures, within 5-6 years, you will be observing some of the anti-malarial drugs which are acting through these novel targets, right. So starting with the first one, that is a translational elongation factor 2, right, as you are seeing that it is translational. So definitely you can predict that it is something with the protein synthesis, right. Translation is a very important pathway for the protein synthesis. So definitely it is, yeah, here I have mentioned as a PF. PF refers to Plasmodium falciparum, right, and rest of the words are definitely the first letters, right, that you are observing, right, with this full form, right. So you can say EF2 is an essential factor for eukaryotic protein synthesis, right. So it is catalyzing the translocation of the tRNA and mRNA. Okay. And definitely once this factor is been targeted, right, if you inhibit this, definitely the protein synthesis is going to be stopped, right. So you have an inhibitor, that is M5717. Definitely if you are not able to remember these examples, do not worry, these are some of the code names which are used by R&D units of pharmaceutical companies, right. Once been there in the market, definitely they will give some name, right. So these are some of the names because it is in a preclinical or a clinical stage, that is why, fine. Second one is a V type proton pump, right, that is ATPase, right. So H plus ATPase, definitely it's a proton pump, and a V type proton pump definitely can be inhibited, right. I have just mentioned is an inhibitor, but you can just mention as a target. So in case of Plasmodium, there is an high you can say influx of the, you can say sodium. To maintain the level of sodium, what it is Plasmodium is doing is it will exchange it with the H plus ion, right. So once there is an higher influx of H plus, right, to you can actively efflux the sodium, right, what it will lead to is a accumulation of, you can say, H plus ions. And once these H plus ions are accumulated, definitely Plasmodium have to find a way to again efflux, right, outside the Plasmodium. This is very much important to maintain the intracellular pH of 7.3, right. Without that, definitely your cellular assemblies will not be able to work properly. So what Plasmodium, what parasite is using is uses a complementary V type of ATPase transporter to efflux, right, actively efflux this H plus ion, right. And if this pump is been blocked, right, definitely by some agents like say for example MMB253, definitely now this efflux is inhibited, pH will definitely get reduced, and once it is reduced, definitely you can say that CIDAL action can be observed. So very novel mechanism that you can consider. Next is phosphatidyl inositol 4 kinase. Again we have mentioned is a PF, that is because that is been observed in case of Plasmodium falciparum, right. So, this definitely is an enzyme, right, which phosphorylates the lipid, right. So, once it is phosphorylated, then these lipids are allowed to regulate, you can say, intracellular signaling, trafficking, right. These all, you can, signaling mechanisms are important for parasital development, and if you inhibit this, definitely the development of parasite is inhibited, right. So, very good target again, and inhibitor is MMV048. Okay, this is again an investigational drug in a preclinical phase. One more target is dihydroorotate dehydrogenase enzyme. This is important. This enzyme, if you just go through the biochemistry of the pyrimidine biosynthesis, you will find this enzyme, and you know that it is a very important, right. So, biosynthesis of pyrimidine is definitely through this enzyme, right. So, to replicate in human erythrocyte, this Plasmodium parasite, they require these pyrimidines, right, which are essential metabolites in all cell, and definitely once this biosynthesis is inhibited, definitely the further growth development could not occur, and that is why it is a very important target, right. Inhibitor includes DSM-265, right. So, these 4 targets which I have shown here, right, they are very important and novel targets. This is just a glimpse that I have given. You can also find some more targets, right, which are used for the development of anti-malarial drugs, right. So, that completes our discussion, right, for the recent advances in the development of anti-malarial drug. I hope I have tried to cover all topics which are related with the anti-malarial drugs. Still, if any positive comments, if questions, queries are there, right, if any questions are there, definitely I will welcome, right, all questions regarding this topic. Okay, thank you very much.